Good afternoon, everyone, and welcome to the third webinar in the APSAC Fontana Center webinar series. This webinar is titled Trauma-Focused Cognitive Behavioral Therapy, TF-CBT, for Children in Foster Care, hosted by Dr. Anthony Mannarino. This webinar will be recorded, and the PowerPoint will be emailed to everyone. There will be time for questions at the end. Please write your questions in the chat or the Q&A section, and they'll be answered later. Now, I'd like to first introduce Dr. Mel Schneiderman, who is the Senior Vice President of the Vincent J. Fontana Center for Child Protection of the New York Foundling, to talk a little bit about becoming an APSAC member, and to then introduce Dr. Anthony Mannarino. Thank you, Mel.
Hi, everybody, and welcome to the third webinar in the 6 webinar series, as Leslie has announced. I am very excited. We have over 1,400 people registered for this webinar, and it's going to be very exciting. If you are an APSAC member and a psychologist, you can receive CEU credits for this webinar for $5. And if you are a psychologist and not a member of APSAC, you can receive CEU credits for $15. If you're not currently a member of APSAC, I strongly recommend you join APSAC today. APSAC is a leader in the field of child maltreatment, is leading several national initiatives to end corporal punishment, to end psychological maltreatment and other forms of child maltreatment. It also offers significant discounts for professional trainings and many publications. I am now very proud to introduce Dr. Anthony Mannarino, who will be presenting today. I'm going to give a short bio because he is extremely well known and most of you know of him. He is currently the director of the Center for Traumatic Stress in Children and Adolescents and vice chair, Department of Psychology at Allegheny Health Network, Drexel University College of Medicine. He is a co-developer of trauma-focused cognitive behavior therapy. He served 2 terms as president of APSAC and served as president of the Division of Child and Family Policy and Practice of the American Psychological Association. Everybody is in for a treat, so let me now hand this over to Dr. Mannarino. Tony, take it over.
Thanks so much, Mel, and thanks for the very kind introduction. I just wanted to first thank Mel and Leslie for inviting me to participate in the webinar today. It's always a pleasure for me to work with APSAC. I've been a member of APSAC since the inception of the organization. It's been one of my professional homes for a very long time. Such a wonderful organization. So I'm always so proud to get an invitation from the Foundling and APSAC to participate in one of their educational programs. I also wanted to just wish all of you well at the beginning of this webinar. This is such an extraordinarily challenging time for all of us, particularly all of you with young children or older parents. You have a lot on your hands these days, managing work and homeschooling and all the other things you're involved in. So just make sure you're taking good care of yourselves and practicing good self-care. We recommend that, of course, to our clients all of the time, and we need to make sure we're doing it for ourselves. So it's a pleasure to have you here today and to take some time out of your day to participate. So I'm going to start out with just talking a little bit about TF-CBT. My guess is that more than a few of you are familiar with the model, but just give a bit of an overview. And then I'm going to really segue into talking about TF-CBT for children who reside in foster care. So as many of you probably know, TF-CBT is an evidence-based treatment for children, adolescents, and their families. It's a model that really looks at the outcomes across many different domains related to trauma, including traumatic stress symptoms, emotional and behavioral problems, cognitive issues, and trauma-related problems. It is a time-limited model, typically 8 to 25 sessions, and the largest focus of TF-CBT is on parallel individual and sessions for the child and for the caregiver, mixed in with some conjoint sessions as well. One of the things that Judy Cohen and Esther Deblinger, the other two developers of TF-CBT, and I are most proud of is that there have been a large number of randomized clinical trials supporting the efficacy of TF-CBT across different age groups, different cultures, many different settings, many different trauma types. And we're just very gratified by that because it's been studied around the world and demonstrated to be an effective model. TF-CBT is both components and phase-based treatment, which I'll talk a bit about in a second. And I do want to mention that a critical part of the model is the use of gradual exposure. And really all we mean by gradual exposure is that we are integrating trauma work right from the outset of TF-CBT. So even in those early stabilization skills sessions, we're really focusing on helping kids to deal with their trauma experiences, their trauma reminders, and so forth. And of course, another really essential part of TF-CBT is the involvement of the parent or caregiver. And it's probably one of the ways that our model differentiates itself from some other trauma approaches, that we've always emphasized the critical importance of the parent caregiver and doing all we can to enhance the quality of the attachment between the child and the caregiver. I want to thank our collaborator and other TF-CBT developer, Judy Cohen, for the acronym practice. Judy knows that I've teased her a lot because she's a physician, and physicians are well-versed in acronyms. And sometimes when we've written grants together, I've teased her about all the acronyms that she includes. And I tell her that most people don't really know what those acronyms stand for. But my guess is that most folks who are familiar with TF-CBT know what the practice acronym stands for. And it's been such a familiar moniker for the model. And we really owe it to Judy for coming up with that. Now, you know, that practice acronym isn't meant to be a rigid or inflexible approach to TF-CBT, but it is really a model of the kinds of things we're doing with kids and families, and a progression through the model, which I'll talk about now. So you can see on this slide an illustration of TF-CBT being both a components and phase-based treatment. So there are 3 phases. There's the stabilization phase that includes what we commonly refer to as the prac skills, and that includes the psychoeducation and parenting skills, relaxation, affective regulation, cognitive coping. That's the first part of the model, and it really builds the foundation for the house. You know, children and parents need to work hard in collaboration with their therapist to build that foundation, because when that foundation is built well, it segues nicely into the trauma narration and processing phase. You know, when we developed TF-CBT, it was very uncommon for children to talk about and process their trauma experiences. Therapists happen that it could re-traumatize them. But I think what we've learned over the years is that if we don't talk with them about it, it doesn't mean that those memories go away. It's still within them. And it can sometimes be like a poison in their body, in their mind, in their brain, in their heart, in their soul, affecting them in very deep ways. So we as therapists need to be brave enough to collaborate with kids to really process their trauma memories. That's the middle phase of the treatment. And then the last third of the treatment is the integration phase, where we work with kids around any in vivo mastery of trauma reminders, conjoint sessions to process the narrative with the caregiver, and then working on safety issues. So those are the three phases of the model. This is just a graphic illustration of the importance of gradual exposure or doing trauma work right from the very beginning of treatment. So on the x-axis, you see the practice acronym. On the y-axis, which you can't see so well on the bottom of your screen, just illustrates the number of sessions. So if you weren't to do any trauma work during the first phase of TF-CBT, and then you went right to the T, or the trauma narration and processing, kids would be very ill prepared to do their trauma narration and processing. They wouldn't have done any trauma work earlier, hadn't worked on trauma reminders, and they're just not ready to do it. And honestly, if you implemented TF-CBT in that kind of way, lots of therapists wouldn't be ready for the trauma narrative either. In contrast, what we like to do is that sort of gradual line going up the x-axis, where gradually, incrementally, step by step, we're increasing the amount of time that kids work on their trauma experiences, such that when they reach the T, or the trauma narration, they're going to be less avoidant, more able to deal with it, and in fact often have made some very significant symptomatic improvements by that point in time, such that they really are better able and better equipped to deal with their trauma details and try to process those with their therapist. So there are really two different pacings for TF-CBT. This is sort of the typical pacing that you see on the current slide, where TF-CBT would be implemented in 8 to 16 sessions. On the left side of the slide, you can see that throughout those 8 to 16 sessions, that there's parenting work going on throughout, and gradual exposure or trauma work going on throughout. And then you see in the middle column that the prac skills take about a third of the model, the trauma narration and processing takes about a third of the model, and then the integration consolidation phase takes about a third of the model as well. In contrast, we do work with many youth who have complex trauma, and complex trauma being defined as typically many trauma experiences early in life, often in their family of origin. And these kids as well typically have very complicated clinical presentations. So they may have PTSD, but they often have other comorbid psychiatric disorders as well. So it's both complicated in their background, complicated in their clinical presentation. And I would tell you that for many youth with whom we work who reside in foster care, that their clinical presentations and trauma backgrounds can be quite complex. So with these youngsters, as you can see on the left side of the slide, the treatment is longer, 16 to 25 sessions. Nonetheless, similar to the typical pacing for TF-CBT, parenting skills and gradual exposure or trauma work goes on throughout the model. But you'll see, in contrast to the typical pacing, that the stabilization phase is much longer. In the typical pacing of TF-CBT, the early phase may be 4 to 5 or 6 sessions. For kids in residential care, in foster care, and other children who present with complex trauma, the stabilization phase can be about half the treatment, or up to 12, 13, 14 sessions. And that's largely because these youngsters often present with significant behavioral and or emotional dysregulation issues. So we really need to work hard in the first part of the treatment to achieve some level of stabilization. It takes longer. with kids with complex trauma, which in turn will better prepare them to get to that trauma narration phase in the middle of the treatment and then progress in the last quarter of the treatment with integration and consolidation. So complex trauma, as you all know, takes longer. And in the TF-CBT model, that greater length is focused on stabilization to really help them get in a better place where they're going to process their trauma experiences more effectively. As I mentioned near the beginning, we've been very fortunate that there have been 23 randomized clinical trials for TF-CBT around the world. 23 trials may not be as many as might exist out there for Lipitor or some of the other large trials that have been done by big pharma, but to have 23 studies supporting the efficacy of TF-CBT is really pretty great for a psychosocial intervention, so we're quite proud of that. You know, Judy and Esther and I have done 9 of those trials as an investigative team, and I want to mention that in all of the trials that Judy, Esther, and I have done, foster children have also been included in those studies. And then as you can see from the slide, there have been studies done in Africa and the Democratic Republic of Congo. The study by Laura Murray in Zambia is really noteworthy because Laura trained paraprofessionals to do the work of TF-CBT, because as you might guess, there aren't a lot of trained mental health professionals in Zambia. So with extensive training and supervision from Laura, these paraprofessionals did a superb job of implementing TF-CBT and achieved remarkably terrific outcomes with these youngsters in Zambia who had been orphaned because of HIV exposure, and one of the parents or also had a history of sexual abuse. And then you can see the other studies done in Norway, in Germany, the Netherlands, and also more recently in Japan, which was a study that was done after the tsunami and earthquake in Japan that had occurred a number of years ago. You know, the summary of these studies are, you can see in the first bullet, a whole variety of different kinds of trauma that we've studied, including sexual abuse, domestic violence, and so forth. In the middle bullet, you can see the variety of outcomes that we've studied and the successes in that regard. But most notably in the bottom bullet that many folks aren't aware of, which is that when caregivers or parents participate in TF-CBT, they also make significant improvements in their own parental distress, in their own PTSD, increased parental support, reductions in depression. And that's not by getting their own individual therapy, that's just by participating in TF-CBT with their child, with the focus of the treatment being on the child. But parents get a lot of involvement, and as you can see from the slide, make a lot of improvement as well. So I wanted to talk a little bit about one specific study because it has great relevance to this talk today on TF-CBT for youth in foster care. So this was a study that Judy and I did a number of years ago in Illinois. We were contacted by the Department of Public Welfare there to see if we could be involved in a study comparing TF-CBT in 2 agencies. It was a quasi-randomized trial, 2 agencies in the Chicago area. I will tell you the 2 agencies that Judy and I worked with in Chicago were on the south side of Chicago that served multi-racial, multi-ethnic groups. And it was a relatively poor area, and the agencies served many children in foster care. There were also 2 other treatments involved in the study. Some of you are probably familiar with Alicia Lieberman's child parent psychotherapy model, which was also implemented in 2 agencies, and then the Sparks model as well, also implemented in 2 other organizations, also in the south part of Chicago and relatively lower socioeconomic areas. And the kids were randomized either to one of these 3 treatments in their respective organizations or to systems of care or treatment as usual. You know, what we found was that in this study that TF-CBT resulted in significantly greater improvement than systems of care for traumatic stress symptoms and also for behavioral and emotional needs based on the CANs. We also found that all of the treatments, SPARCS, CPP, and TF-CBT, were much more effective than systems of care in preventing foster placement disruption. Now, I'm sure most of you know that foster care disruption largely occurs because of behavioral difficulties. And the foster parents just feel like they just can't manage a youngster's behavioral problems any longer. So with SPARCS, with CPP, and TF-CBT, that these placements were about 1/2 as likely to be disrupted when these youngsters were getting one of these 3 treatments compared to getting systems of care. And that's good news, because the more the kids can remain in a stable placement, the better their outcomes are going to be. And the other finding that I'll mention that I think is important is that for TF-CBT, children were about 1/10 as likely, these are foster kids, of course, about 1/10 as likely to run away. And with SPARCS, about 1/2 as likely to run away from placement. So I think the results of this study suggest, 1, greater improvement in terms of trauma symptoms, 2, less disruption of placement, 3, less likelihood of running away and the dangers associated with that. And so I think you get better clinical outcomes based on this Illinois foster care study. Plus, for the Department of Public Welfare in Illinois, because of less runaway, less placement disruption, it reduced their costs as well, which is another important part of the equation. I wanted to share that study with you since it's applicable to our discussion today about TF-CBT for youth in foster care. One quick slide before we really jump into the foster care implementation. We still continue to have our web-based course. In the first course, we had over 350,000 registrants from around the world. We initiated TF-CBT Web 2.0 about 2 years ago, January 2018, and it continues to thrive just as much as the original web-based course. For any of you that have taken the course, we really appreciate your involvement. Okay, so let's really spend the rest of our time talking about the application of TF-CBT to youth in foster care. So one of the things we certainly know is that youth in foster care typically have experienced trauma of some type in their family of origin or some type of adverse child experience. So it may include things like sexual abuse, physical abuse, domestic violence, or the parents who've been involved with drugs and alcohol and not able to care for their children to the degree that they could. Perhaps that's resulted in some level of neglect. So kids in foster care typically wind up there because there's been some kind of trauma, neglect, or adverse child experience in their family of origin. And that's important because, one of the 2 things that you need in order to really consider a child for an evidence-based treatment like TF-CBT is that they've been exposed to a traumatic experience or to an adverse child experience. And then secondly, many youth in foster care who have that kind of trauma history also may well have mental health diagnoses associated with these experiences. And that may include PTSD and anxiety and depression. and then also trauma-related behavioral problems. So it's really those two things, the combination of having experienced the trauma and having trauma-related symptoms, that really accounts for these youngsters being eligible to receive TF-CBT as a potential treatment. Now, of course, many of you know that for most of these kids being placed in foster care, maybe I shouldn't say most of these kids, but certainly for some of these kids, being placed in foster care is extremely traumatizing. Being separated from their family, from their mom, their dad, their siblings, can really be an instance of traumatic separation. Over the years, I've had many, many therapists tell me that kids have told them that the worst thing that they've ever experienced was being separated from their family. And that's true even if these youngsters had other trauma experiences in their family of origin. And we often underplay that. You know, we think, wow, they're going to mention abuse or domestic violence as the most difficult thing that they experienced earlier in their life. But often it's that traumatic separation from their family, and that often becomes a focal point of the work that we do with kids in foster care as part of TF-CBT. So what are some of the barriers that exist for providing TF-CBT for youth in foster care? Some of the barriers may be perceptual barriers that have been endorsed by foster parents, and we really learned a lot of this through some of the wonderful work that Shannon Dorsey and her colleagues at the University of Washington have done. So sometimes foster parents are reluctant to have their foster children involved in psychotherapy or other mental health services because of negative prior experiences. And based on those negative prior experiences that either kids didn't enjoy going or that kids didn't benefit from going, that sometimes foster parents may be quite reluctant to have their foster children involved in psychotherapy and other mental health services. Foster parents are often unsure about what their role will be when children are getting mental health services. In fact, what we often hear from a lot of foster parents is that typically when their foster kids are involved in treatment, that they're not involved at all. As our dear friend Lucy Berliner likes to say, kind of like dry cleaner therapy, where you drop the kid off for an hour of therapy and then you pick him up when he's done. And of course, as you all know, for TF-CBT, what we offer is really directly opposite of that. That parents, including foster parents, are an integral part of the TF-CBT model. And we really try very hard to communicate that they're going to be an integral part right from the very outset. And then another perceptual barrier can be that sometimes the therapist can be viewed as just another part of the child welfare system. And, you know, sadly, biological parents and sometimes foster parents may not have much trust in the child welfare system. And if they see the therapist as just being allied with the child welfare system, then that could be a barrier that gets in the way of foster parents wanting to bring their children in for mental health services. Some of the concrete barriers, of course, many foster parents have a large number of child care responsibilities. There are other younger children in the home more than once in a while. There may be transportation issues. You know, you guys may be interested to learn that in our clinic here in Pittsburgh, our Center for Traumatic Stress in Children and Adolescents, that prior to the shelter-in-place order, we had about a 30% no-show cancellation rate for our families, many of whom included kids in foster care. Interestingly enough, since the shelter-in-home place has been on the table and we've switched over to telehealth services about 7 or 8 weeks ago, our cancellation or show-up rate or no-show rate has been on the order of about 10 to 15%, basically cut in half. So some of those concrete barriers of transportation and having to take care of younger kids at home are not as formidable when we're able to do some of these services delivered through telehealth. There's also concerns about the stability of placement. Sometimes therapists are hesitant to initiate TF-CBT or any other treatment for that matter because they're concerned that these children will not be in this particular foster placement that long. It's not a permanent placement. Child could be removed, and therefore you might wind up starting a model like TF-CBT, and then you get halfway through, and then the kid's removed from the home, and then you wind up not being able to complete the treatment. And that's certainly a real barrier that therapists have to deal with. I will tell you that my experience has been that even when a placement for a child in foster care is not permanent, often it is for several months. And if it is going to be for several months, that's often a long enough window of time to actually get started with TF-CBT and complete the model. And that is one of the benefits of a shorter term approach, that you don't need years to get the work done. And even if the placement happens to be relatively brief, there's a pretty good likelihood that a child will be able to finish TF-CBT. There are legal issues involved when implementing TF-CBT with youth in foster care. For those of you who work with children in foster care, of course, you're going to be familiar with these kinds of issues. In our clinic in Pittsburgh, we always have the barrier of who can provide legal consent for treatment. In Pennsylvania, foster parents cannot provide consent, and often even the child welfare agency can't provide consent. Our coordinator often has to get the consent of the biological parent even when the child is in foster care, and sometimes that can be quite a challenging task. So our coordinator is working hard to get that consent. Certainly, clinicians in their respective states need to know the laws around consent in order to understand better whether you have to get that consent from the biological parent whose rights haven't been terminated, from the foster parent, or in some cases from the child welfare agency itself. Another legal challenge for kids in foster care is trying to maintain the confidentiality of treatment. Remember, when kids are in foster care, that the quote system is involved, and that typically means the child welfare system, and often the family court system as well. And there are folks out there, including caseworkers and lawyers and judges, who would really like to get a great deal of information about the child's treatment. They want to know what the kid's talking about and how they're processing their experiences and so forth. And you're often going to get third-party requests for treatment information. And in fact, for TF-CBT, the greatest request is often for the trauma narrative. The reason why we often get that request as part of TF-CBT is because third parties out there, child welfare workers, judges, lawyers, don't understand what the trauma narrative is and what it is not. They often think it's some kind of investigative interview where children report the actual facts of their trauma experiences, when in reality, a trauma narrative and processing is all about a child sharing their subjective perceptions of their trauma experiences and most importantly, processing their thoughts and feelings about their experience. So outside parties really don't understand what it is, and we've really spent a lot of times over the years trying to help outside folks understand what a narrative is and what it is not. And in fact, we've created a document called the TF-CBT Trauma Narrative Disclaimer, which I'd happy to share with all of you in regard to educating the community about what the trauma narration process in TF-CBT is, and also explicitly what it is not. And then I will also mention as well that, we can get subpoenas and that kind of thing to testify in court about treatment, the likelihood that these kids would be exposed to abuse in the future, should they stay in placement and so forth. In our center in Pittsburgh, we try to make a very strong boundary between treatment and the legal system. And we try very hard to have our therapists not testify in court and provide this kind of information. Now, I appreciate certainly that in many jurisdictions around the country that things are different, and that often therapists are being asked to testify in court and provide information to the court about what the child's talking about. And all I would say to therapists who are in those kinds of jurisdictions is just to be careful about that kind of issue, because when children find out that you've shared with the court or caseworkers about their trauma experiences, and specifically what these kids have told us about their thoughts and feelings about their trauma experiences, sometimes they can really experience a very strong sense of betrayal. Okay, so initiating TF-CBT with youth in foster care. Again, we often wonder whether there's going to be sufficient time while the child's in foster placement to really complete the work, right? And as I said a few minutes ago, often kids will be in a foster placement, even if it is temporary, for 3 or 4 months. And that 3 or 4 months often does provide enough time to complete a short-term treatment like TF-CBT. The second question that often comes up is, well, how long do we need to wait for a child to be stabilized in a foster placement before we initiate a model like TF-CBT? And of course, we're probably not going to start the model the week that a child has begun a new placement. But on the other hand, we don't need to wait 3 or 4 months. I would say that very often in our center, we would wait 2 to 4 weeks for a child to obtain some level of stabilization in his or her or their placement, and then we would initiate TF-CBT at that point. Another question that commonly comes up is, which parent should participate in TF-CBT? Should it be the foster parent? Should it be the biological parent? Or maybe both? I will certainly tell you that if the child's going to be in a foster placement for a while, we really should involve the foster parent in the child's treatment. The foster parent at that point in time has the greatest amount of contact with the child, knows what's going on in terms of sleep issues, mood of the child, behavioral problems. If you're really wanting help with managing behavioral difficulties, you've got to have the caretaker involved who's actually living with the child at the present time, and that's going to typically be the foster parent. Now, of course, if it's quite likely based on information from the child welfare worker and the court that a child is going to be returned to his or her or their parent of origin in the relatively near future, then of course you want to have the biological parent involved as well, because you want them to know something about your TF-CBT work with their child. And in some cases, you might actually involve both the foster parent or biological, or I should say foster parent and biological parent, although it's completely understandable that you might not involve the foster parent and biological parent in the same session. So some of the clinical challenges and clinical issues involved in working with youth in foster care when implementing TF-CBT. As I mentioned at the top of the presentation, it's more likely that these youngsters will have a complex trauma presentation because of multiple traumas in their family of origin, a more complicated clinical presentation. They're more likely to have greater affective and/or behavioral dysregulation. They may have some history of non-suicidal self-injury and so forth. So because of that complex trauma presentation, treatment is likely to be longer. So I would say with many of the youth whom we treat in our center here in Pittsburgh, it's more likely that TF-CBT is going to be in that 20 to 25 session range instead of the more typical pacing of TF-CBT, which may be in that 12 to 16 session range. Additionally, because these youngsters are not in their family of origin, perhaps there's been abuse in their family of origin, and many of these youngsters in foster care may well struggle with issues of trust and safety. Safety and trust should really be the first component that we focus on in the treatment. You know, in that practice acronym, enhancing safety and future development is typically at the end, but really for most of TF-CBT and certainly for kids in foster care, enhancing safety, enhancing trust should really be implemented right at the front end of the model. It's also true that youth in foster care may be reticent to have their foster parents participate, particularly if they've not been in this foster parent very long, in this foster home very long. They may have some trust issues with the new foster parents. And to some degree, we want to respect that with these youngsters. But on the other hand, we really encourage our therapists to educate kids in foster care about what would be the benefits of having their foster parent involved in treatment, including educating the foster parent about the impact of trauma and why kids might be having some of the difficulties that they're displaying in the foster home. And we can certainly try to involve the foster parent in that kind of way, while at the same time respecting the confidentiality and the privacy of the information that a child shares with the therapist in the individual sessions. And then, of course, you've got the issue of, can these youngsters really trust their therapist because they've had a history of betrayals in their life, maybe a history of betrayals in their family of origin, a history of betrayals in the judicial system, and maybe with other therapists prior to the current therapist whom they felt were judgmental with them. So because of that, the trust that foster kids may have in a therapist may take a bit of a time to really formulate. What are some of the additional clinical issues? Well, kids in foster care may be quite reticent to discuss their trauma experiences. They may feel like this is a betrayal of their parents. Remember, even if they've been victimized by their parents, it doesn't mean that they're not attached to mom and or dad. And if they talk about these trauma experiences, they may feel like they're betraying mom and dad. They're also worried if they talk about the experiences, could mom or dad be punished for what they're talking about? Or when these kids want to be returned to their mom and their dad, could there be a delay in reunification because they're talking about their trauma experiences? We also have to be concerned about ongoing visits that these youngsters typically have with their biological parents during the course of TF-CBT. Many of these kids, of course, want to have these visits because they're hoping to be returned. On the other hand, some of the kids don't want to be visiting with their biological mom and dad. Maybe they're angry at the parents for the abuse and neglect that they may have experienced. So you never quite know what you're going to find. So these kids may wind up having very mixed loyalties. On the one hand, they're happy to be living in a safe foster home, but on the other hand, they may miss mom and dad and their siblings and wish to be reunited. We also know, of course, that after visits with mom and dad, their biological parents, either because they miss their parents or because they feel scared when they visit with their parents, that there could be an increase in behavioral difficulties after these visits. And therefore, we have to work closely with foster parents around addressing these behavioral issues, addressing sleep problems, and other things that crop up after visitation occurs with the biological family. As we talked about a few minutes ago, a very common reason for placement disruption in foster care is because of the behavioral problems that these youngsters present with. And all parents, including foster parents, often need our assistance in dealing with these behavioral problems. They need psychoeducation, first and foremost, so that foster parents can really understand the connection between the trauma exposure that these kids have experienced and the behavioral problems that are presented in the foster home. Lots of foreign foster parents really don't understand that connection. They just think maybe the youngster has inherently difficult problem behaviors. And it's really up to us as therapists to educate foster parents to understand that connection between exposure and behavioral problems. Over the years, it's been my experience that when foster parents understand that connection better, they're more receptive to behavioral interventions, and they develop a greater sense of compassion for their foster child because they better understand what the origin of some of these behavioral difficulties are. And of course, it then provides the opportunity to work with foster parents in regard to specific behavioral interventions for those behavioral difficulties. When there's uncertainty about the stability of the placement, and sometimes that does occur, we encourage therapists to really work on consolidating the prac skills and really to only go forward with the trauma narration and processing if you feel like you've got enough time to complete it. If a youngster starts a trauma narrative and has to stop in the middle because they're changing placement or the placement has ended, it's not, and they can't finish their trauma narration. It's not the same as someone getting brain surgery and it's not completed. But there is something to the idea that a kid who starts a trauma narrative and can't complete it, it sort of results in a youngster really opening up Pandora's box and not being able to close it up in an effective and successful way. So we really encourage therapists, if you can't complete the trauma narration and processing with a youngster in foster care, to just really consolidate prac. But if you're going to try to do the trauma narration and processing, you really need a commitment from the foster parent that they're going to attend the next 4 to 6 appointments so that the foster child does have that opportunity to share the trauma experiences and be able to process their thoughts and feelings about it. I want to mention, as getting near the conclusion of my talk, that we do have a manual. It's called the Trauma-Focused Cognitive Behavioral Therapy for Children in Foster Care, an implementation manual that Esther and Judy and I and our colleagues put together several years ago based on a learning community with about 12 other centers around the country that were serving children in foster care. And I would be more than happy to share this manual with anybody who's participating in the webinar today. And lastly, what I want to share with the group is, in this era of COVID-19 and with many, if not most of us, transitioning to TF-CBT through telehealth, we've been really fortunate to work with our colleagues from the Medical University of South Carolina, who had been studying TF-CBT for several years and had been finding in a pilot study for it to be just as effective through virtual platforms as through face-to-face sessions. So if you're looking for resources in regard to doing TF-CBT via telehealth, if you go to our therapist certification website, TFCBT.org. On the home page, you will find a link for all the resources that you see listed on this slide, including a 3-hour video on implementing TFCBT, Word versions of our TFCBT workbooks so that you can use them in video conferencing sessions. And Judy's done a lot of work over many years with Sesame Street Workshop, and Sesame Street has agreed to let us have links on our TFCBT.org website for some of their really terrific videos that relate to our TFCBT practice components, particularly on relaxation strategies, on feeling, identification and expression, and also on cognitive coping. In fact, I was watching the other day this beautiful song being done by Bruno Mars and some of the Sesame Street characters on never giving up and always trying your best as a successful coping strategy. So lastly, I would just say to all of you, the wonderful Maya Angelou, the world has changed one child at a time. And thanks to all of you for what you do for children exposed to trauma. And again, just say to you, please take good care of yourselves, good care of your families during this difficult time. Maintain hope. We're all going a bit stare crazy, but that's not so bad compared to the many hardships that so many people around the country, and most notably in the New York area, have suffered related to COVID-19. And my heart really goes out to everybody whose families have endured sickness and loss of life related to COVID-19. So take good care of yourselves and your families. And Leslie and Mel, we've got time now for some questions if people have any.
So you can hear me, Tony?
I certainly can.
So we have a lot of questions. We're going to try to get through as many as we can. We might go over the time, but this whole webinar is being recorded and will be sent to everybody who is registered and who was on here today. So if you have to, we'll send it to you. So one of our first questions that I'm interested in is, how do you approach mandated reporting when doing TFCBT? This person said they explained at the beginning, but they're afraid of losing the trust of the child, of having to report any abuse and neglect during the therapy.
Yeah, well, of course, we're all mandated reporters, and the way we deal with that issue is by telling kids and families right from the outset that if we hear of previously undisclosed abuse, that it's going to be our job to protect them and other children by having to report that. So we're upfront with families about that at the beginning. I have to tell you, over the years, when we've had to make mandated reports in our center, we tell children that's to make sure they're safe and other children are safe. And, occasionally it does result in some disruptiveness in the treatment, but I would tell folks that the great majority of time, most kids are okay with it. And I think it's based on how we're telling them right at the beginning that that's part of the mandate that we're required to do.
Thank you. A couple of people are asking if they can get a copy or a link to the manual. Is there any way that that's available for people later on? I'm happy to distribute it.
Yeah, so if people go, certainly I'll make it available to you, Leslie, but additionally, if folks go to our website, TFCBT.org, look under resources, you will find that manual there, as well as several other TFCBT manuals, one for implementation with military families, another one for implementation for kids in residential care. And our most recent manual that was developed in conjunction with Caitlin Ryan from the Family Acceptance Project out in San Francisco on the implementation of TFCBT for youth who self-identify as LGBTQ.
Great, thank you. And the people are also asking about a link for the disclaimer too. Is that on there, or is that something you can send to me as well?
You know what, it's not on there, Leslie, but I'm happy to send it to you.
Okay, great. A lot of people are also asking, recommended age to start TF-CBT?
Well, our very first treatment outcome study was with children ages 3 to 6. So we do TF-CBT in our center all the time with children who are preschool age. So it's a model that can be effective with young kids. But of course, please remember that even though the model is for children ages 3 to 18, how it's going to be implemented will be very different with kids of different ages and different developmental levels. And of course, with young preschool children and young primary grade children, we're going to use a lot of play strategies to implement the TF-CBT components.
Thank you. Another question somebody asked earlier was how to address the role of a guardian ad litem or a CASA volunteer. Would they be appropriate person to be involved during TF-CBT?
Well, you know, with guardian ad litems or with CASA, of course, they are typically entitled to treatment information. But you know, that doesn't mean we want them involved in the treatment. I mean, we certainly want to provide information about the nature of the treatment, how the child is progressing, and all of that. But in order to make sure the treatment is confidential and that the child in that private context can share their thoughts and feelings about their trauma experiences, we don't want to give all that information away. Because if children believe that the information they share with us is going to be given to outside parties, it will greatly reduce the likelihood that they'll share the most difficult parts of their experiences. So we do collaborate, of course, with CASA and guardian ad litems, but we don't give them the verbatim progress notes that we create for kids receiving TF-CBT.
That makes a lot of sense. Thank you. A couple people asked, how does a foster parent or how does someone address regression post therapy or post visitation?
Well, that's a tough one. So when kids visit, I think you're meaning, Leslie, when they visit with their bio parents?
Yes, that's what I meant.
Yeah. So this may occur because they miss their parents, or it may occur on the opposite end of the spectrum because they feel scared of their parents. They're afraid they might be reunited. So I think what we'd like to do is educate foster parents about why these behavioral problems after visits might occur, and then try to put a plan in place as to how to address those problems. So maybe after kids return from a visit, can we have some soothing and relaxation activities that children and foster parents can be involved in? Be on the lookout for sleep problems that may occur after visits with bio parents, and try to set up some sleep routines that are going to be conducive to better sleep, and to try to manage any behavioral problems that come up in proactive ways and using a lot of positive parenting. So I think the most important thing, Leslie, is trying to anticipate that these problems will occur. And it doesn't mean anything negative about how these kids feel toward the foster parents, but it's the many issues that crop up when they're visiting with their family of origin.
Great, thank you. I'll do a couple more questions. Another question was, is it recommended to start TF-CBT while a child is currently going through a legal proceeding for a traumatic event that's going to be addressed in therapy? When is it advisable to start if that's not the case? And do you have any other recommendations before jumping into TF-CBT if they are going through a legal proceeding?
Yeah, that's a great question, Leslie. You know, when abuse and other trauma are being investigated by the child welfare system, I think we would agree that it's probably not a good idea for kids to be getting into the heart of their trauma narration and processing, and really should wait until child welfare has done its investigation and completed that. If there's a criminal proceeding out there, the problem with those proceedings is that they can be delayed for months and months and months, if not years. And if we were to wait for TF-CBT to be started until a criminal proceeding were initiated, these kids could be suffering with these traumatic stress symptoms for months and months, if not longer. So what we do is we do forward if there's a criminal proceeding to implement TF-CBT. Of course, we're not coaching children about what they would testify about in court. But on the other hand, we believe it's important to go forward with the model because otherwise they could be suffering with traumatic stress for months, if not longer, if we're waiting for a criminal proceeding to be started.
Thank you. So somebody also said, and this kind of has to do with everybody dealing with COVID-19 right now, somebody said that a lot of children in foster care need trauma therapy. How does anger management implemented in this treatment, especially now during COVID-19 that children have less ways to cope with their anger?
Yeah, well, boy, that's a great question because it's a lot harder to cope with a lot of things these days because families are in close quarters and, you know, school and work all kind of integrated together. So, of course, with TF-CBT, coping skills, relaxation skills, affective regulation skills are a big, big part of the model. And even when kids are at home, we're going to be working with them about how to express anger in appropriate kinds of ways through feelings, through words. We're going to be working with foster parents or bio parents to learn to manage those behaviors more effectively, try to really provide information to parents about positive parenting. And I think we're probably going to talk with both parents, whether it be bio or foster parents, and the children about sort of cutting each other a break. That it's likely during these difficult times that there could be more irritability or more stress for sure. And just to give each other a break that sometimes we're going to get irritable and angry and it may not be such a big deal. But if it is a more significant problem, we're working with the youngster around anger management, affective regulation, and working with the parents as well around how to address these difficulties through behavioral interventions.
Thank you so much. So I'm going to ask one last question and then we're going to wrap it up. I'm sorry for everybody who didn't get to your questions. Because of the requirement that there's caregiver participation, are children in congregate care, such as group homes, RTCs, not eligible for TF-CBT?
Yeah, that's a great question. And kids in group homes and residential care are eligible. And sometimes if there's a direct care worker or direct care staff member in the group home or residential setting with whom the child has a very trusting relationship, that person could be involved in TF-CBT with the youth as long as the youth wants that person to be involved and there's a trusting relationship and we feel that that person would be appropriate. So absolutely, kids in group care and group homes in residential settings, they are absolutely eligible for TF-CBT.
Great, that is very good to know. Thank you so much for your presentation. I really appreciate it, and I appreciate all the information you gave to us today.
And Leslie and Mel, thanks again for inviting me. As I said at the beginning, APSAC's been a professional home for me for 35 years, so it's always a pleasure to work with you. And to everybody listening, take good care of yourselves and your families. Keep the hope up. This will certainly end somewhere down the road. Take good care, everybody.
Thank you so much. Goodbye, everyone.
Bye-bye.